Good morning, everybody. Just letting you know that you can join us on Twitter. We've got a Twitter handle here. We've got a hashtag #EdgeTalk, or you can use the handle @SchoolForRadicals and @TheEdgeNHS. So we'd love to hear your views on this important subject, talent management in nursing. So please join us, or you can join us here on the WebEx and just tell us what you think about this subject in the chat room, or just introduce yourself and what's your interest in this area. So we're going to start in about a couple more minutes, but we'd just love to hear from you. We'd love to say good morning and see how you're doing.
Never mind. Click a blank, it'll be fine.
You're looking lovely, Sue.
Thank you very much, Janet, and you too. Give it up. Good try.
Okay, it's 9:30. I'm just going to give it a couple more minutes for anybody, last-minute people who want to join in this conversation to come online. Just a couple more minutes, and then we're going to make a start. Okay, it looks like we can start now. It's 9:31. I'm hoping everybody's ready to go. We've got a very, very interesting area, one that I'm very passionate about. On the subject here we're going to be talking about is talent management in nursing. Why does it matter to frontline staff and managers in the NHS? And the presenter is going to be Sue Haynes from Nottingham University Hospital, Assistant Director of Nursing. I'm going to introduce her a bit more formally, but before I do so, I'd like to just give you some housekeeping. In terms of joining today, we've got a Twitter and a hashtag that we'd like you to start using. So the hashtag is #EdgeTalk, and the handle is @SchoolForRadicals, as well as @TheEdgeNHS. So send a request to join our Facebook group, School for Health and Care Radicals and the Edge NHS. So we'd love to hear from you. Please join us on Facebook, and we'd love to hear your comments about this session today. So my name is Janet Wildman. I work as an associate with the Horizons Group NHS England, and I'm going to be chairing the session today. So if you've got any questions for me, please raise them in the chat room. And Dominic Cushion, he's going to be leading on the chat room today, so he's going to be monitoring the conversations there and feeding in at different points in the presentation. And he's also going to be looking at Twitter, so if you've got any questions, please raise them in the chat room or raise them through our Twitter hashtag. I'd like to go on to just introduce Sue Haynes, and she's got a very impressive background, and it's worth me just quickly saying that Sue started qualifying in around 1985 as she was on a medical unit at NHS at the Nottingham General Hospital before moving into to specialise in intensive care nursing. She worked in units at Queen's Medical Centre and Nottingham City Hospital over a period of 16 years as a staff nurse, and went on to become a clinical educator and practice development lead. She has an interest in education, staff development and support, and this is very evident in the presentation she's going to be making to us today. She went on to become appointed to an Assistant Director of Nursing post in Nottingham City Hospital, working within the Nursing Development section, and also went on to become an Assistant Director of Nursing across Nottingham University Hospital's NHS Trust within the new Nursing Development team. Within her current role, she has a specific interest and responsibility for nursing education, practice learning, and loads of other really important areas of talent management. She's got a research interest, and she's currently studying a doctorate. So, hey to all the doctorate students like myself, studying at the moment part-time and holding everything down. And again, her research interest is around talent management. We'll hear a lot more from her today, so I don't want to take up too much time. I want to hand over to her, and I'll be coming back later on to help with the conversation and the questions. So over to you, Sue. Look forward to hearing this wonderful presentation.
Thank you very much, Janet. Thank you very much for the introduction. So today, I think there's some other information on the slides that the Edge have provided about how people can connect in. So I'm just going to go through those first, and yourself and obviously Dom doing the Twitter monitor and the chat room. So that's great, and it's a new experience for us, this concept of teaching and networking across the web. So we're very excited. So I'm here today. I was invited, and thank you very much, to share some, and it is the findings of my actual doctoral research, which I have just passed, so I'm feeling greatly relieved currently, and yeah, empathise with everybody studying well out there. So the initial idea was to give some feedback on the findings of the research, and then also what we've been doing about the findings within our organisation here. So I'm really delighted that I've got colleagues here to share with people today some of the key ideas. So it's some examples of work we've been doing over the past 3 years here at Nottingham to help sort of prompt some discussion really, and share with others and hear what others are doing too. So I've got Dr. Joanne Cooper here, our Head of Nursing Midwifery Research, Kerry Taylor, who's our Shared Governance Facilitator, and Ted Randall, who's a Staff Nurse and Chief Nurse Junior Fellow, and they'll be taking part in the discussions as we progress through. So the aim of this webinar, from our point of view, was to report on the findings of some of the research that we've been doing here. Particularly, my research is around talent management in nursing. But what I've found through my networking across the country and with different professional groups is some of the themes are very, very similar. And my particular interest is frontline staff. So I'll share some of those findings and then go into some of the examples. So that's the plan for the session. And we'd really like to facilitate some wider debate and discussion because we feel this is such an important topic. And our approach is very much about inclusive talent management. And we welcome all discussion and debate about how we might do that within nursing and within healthcare. So I'm just going to start with some of the basic background and some of the work I've done through doing my research. I looked into it as a healthcare professional who didn't know much about talent management as a concept that was more familiar with business and HR management. But I was very conscious when I started my study that I was very interested in retention of staff. How do we develop our very, very able nurses, our newly qualified, when they come into our organisations? The other challenge we know is we've got the ageing population. We've got a global, health demand for care workers and registered nurses as well, particularly. And we also know now, with the contemporary changes to the bursary going, changes to nursing workforces and these national shortages, that actually nurses have got to compete, attracting people into nursing who now could go and choose to do any other career. Particularly now, fees are going to be included for undergraduate nursing courses. So we've got to make nursing an attractive profession. We've got to make sure that we've got the right skills and the right people coming into nursing. So one of the thoughts, the feedback we got through our staff here was, when you're newly qualified, you come out into nursing particularly, and you don't really know what career pathways you can go down. The fact that there are so many routes that you can go down in nursing, and actually what newly qualified staff were saying to us is, we don't know what's there, and we don't know what we don't know. So when you look at talent management as a concept, I think it's much more widely referenced in healthcare probably today. But when this research started, it was very underwritten about within healthcare. So I was looking into what did business say it was about, and there was many definitions of talent management. And the one thing I've learned from doing this study is that the whole concept of talent management, there tends to be an agreement in the literature that it is an under-researched concept. It's inconsistently defined and it's poorly evaluated. And there are many different models of talent management when you're looking out into the literature. So one of the most key definitions that I looked at in terms of my research was at the time one that I identified from CIPD in 2010. What they said was talent management was a systematic attraction, identification of individuals, I won't repeat the whole quote, but it was about having value either because you're high potential or because you're business critical. And how organisations and businesses define what is business critical is quite an interesting point. But when I looked into it much deeper, what I found was that the literature was in a way on a continuum. So when you talk about talent management, people often automatically assume you're going to talk about exclusive models. So that's very selective approaches, where people are identifying high flyers in inverted commas, having top talent pools. And a lot of the literature, particularly in the NHS and health, was around high leadership, people aspiring to be directors, rather than frontline staff. So on the other end of the spectrum, and much more emerging over the last 4 to 5 years in the literature, is an ethos of a more inclusive model of talent management, where there are opportunities open to all. This is based around staff engagement models, where there are open and transparent processes, and a model such as shared governance, which we're going to talk about a bit later on in this session. So within an inclusive model of talent management, individuals nominate themselves and become engaged themselves for opportunities, rather than being selected by senior managers. And that's now the model that the NHS Leadership Academy and their sort of 2014 quote about inclusive talent management was around everybody should be considered talent, and the value is the diversity of talents. And in a way, if we look at the breadth of talents we have within healthcare, certainly, and within nursing, from our point of view, it's the inclusive approach, which is recognising diversity rather than very selective niche talents. That is the optimum approach to take. So what I'll show you is some of the findings of the study that I actually did. So the core components that we have defined within our model of talent management include a continuous process of recognising what talent is for your organisation. So how are you defining what talent is? Now, for us in nursing, that might be such diversity in things. And also, it's what outcomes are we expecting? So what do talented nurses do for patients, basically? What are the outcomes we can expect? How do we attract talent, however we define it? How do we develop, manage, and evaluate? Something the international literature shows is that there is a lack of evaluation overall in processes that are used. There's a lot of opportunity for us to inform the literature and the evidence base for practice. So my research study aimed to gain new insights and knowledge into how talent management was emerging as a concept in nursing, and to look at what our frontline clinical nurses were saying and what their experiences were. And these were a brief summary of my questions. So how did people define what talent was in nursing? How did they describe the challenges of attracting and developing the talented nurses? And in a way also, what were senior board level staff thinking about talented nursing? So I've undertaken an exploratory case study, qualitative, and it included a range of data collection, including documentary sources and a really wide consultation exercise to engage. And this diagram just shows a sort of a representation of the data sources used. And the wider consultation that we had involved 229 staff nurses from across our organisation. So this was to make sure we were really engaging with our frontline staff to understand what talent meant to them and what they felt was important for us to be recognising in the organisation. So the results of the study are clustered thematically under 3 core themes, and these are outlined here on this slide. So the first one is nursing as talent. The second one is leadership and culture. And the third one is career development. And what I'll do is I'll just outline the core aspects of each theme. So, how is talent defined in nursing? Now, the main finding here was that there was such a diversity of skills and attributes that our participants raised as talent in nursing. Nurses valued what they did, but what they were concerned about is that talent in nursing was not recognised or valued wider in nursing or in organisations. So whilst there's a diversity, what they were saying was people aren't recognising what nursing does as talent. So there was something about recognise and reward. There was something about nurses feeling very understated about what the talents were that they had. And they were recognising just as everyday skills and not really realising the positive impact they had. There was issues around people identified core areas, leadership skills, interpersonal skills, patient-centred skills, and professional knowledge and skills. So the other interesting component was nurses, again, they were very much unaware of wider diverse talents. So the clinical nurses were not necessarily thinking of talents required to be a nurse educator or a nurse researcher. They were very much thinking around the talents to be a clinical nurse and valuing and recognising the roles that they did. Interestingly, executives involved in the study were very, very positive about nursing talents, whereas what the participants were saying is that there is a negative media image of nursing. And I think that's something we've talked about quite widely within the media and across social media over the past couple of years, particularly since the Francis report, which rightly recognised things in nursing. So these participants, when asked what was talent in nursing, they said people don't know what nurses do, and they wanted to have a reclaimed pride in nursing as a profession. They said excellence wasn't recognised, often only what hasn't been achieved. So there was a performance culture where people were expected to deliver on targets, but they weren't really recognised if when they did well. But recognition of talent was important in nursing, and it's not just about senior bands and high flyers, or those who shouted the loudest. There was a whole notion of inclusivity and recognising the team, and people wider than those people who shouted out the loudest. So the other key identified finding was career pathways. So the invisibility of nursing careers. You don't know what you don't know. What are the career pathways? And one of the most interesting points was a lack of clinically focused career pathways in nursing, which I think is widely referenced through other literature and previous studies, including government and policy reviews, such as the Prime Minister's Commission on Nursing. Nurses talked about wanting a climbing frame for careers, not just a ladder. So opportunities to move laterally, not just up a hierarchy. And that this is critical for recruitment and retention. The need to recognise and value the Band 5 staff nurse role was absolutely pivotal, because the Band 5 staff nurse role was valued by many of the participants, and it's what they wanted to be fulfilled and valued for that role, rather than feeling they had to move on to get recognition. So the most familiar pathway was managerial, and I'm sure people won't be surprised to hear that. So the ward sister or charge nurse was not seen as an attractive role. And again, I think we have seen this throughout the literature of nursing. The participants identified there's only one pathway. You'll see here this quote from one participant. You see, you become a staff nurse, you become a sister and a matron, and not everybody wants to go on that route. But the one thing that came through very clearly from our perspective in this study was that there was a real lack of knowledge about what career pathways, and it links in now to the shape of caring findings, and also through the Lord Willison report from a couple of years ago. So the invisibility of nursing careers was identified. Certainly clinical academic careers were very poorly understood. They were described when prompted as boring, office-based, people with clipboards that come on. There was a real lack of understanding about what a clinical academic career may look like within nursing. Now, if we're attracting and wanting to attract and retain people from diverse backgrounds into nursing now, we need to be clear about the diversity of careers that we have available. Specialist nursing was the most popular career route for our participants, but people didn't know how to get into them. So for us, we'll know, and nurses out there will know, if you want to be an advanced nurse practitioner or something a specialist role, they're all different in every single organisation. Every single specialty sometimes there are different routes, and that is now being addressed through Shape of Caring, and that has obviously been identified as a key area of improvement. But it's something that's really, really important for our career, I think, and our future. Other routes in nursing were described by our participants as taking nurses away from patient contact. And that was regarded as really, really important, because actually what nurses were saying is we came into nursing to have patient contact, and career routes were a problem. So nursing education, there was limited awareness of education roles. And for community, another, in light of the 5-year forward view, nurses from an acute care setting were not talking about careers in community. So there's something there about the visibility of nursing careers. Ward leadership and culture then. The sister charge nurse, the line manager, was seen as the key talent developer, the key individual that could enable opportunities or block opportunities. They were seen as the gatekeeper, and the qualities and skills of the sister charge nurse or line manager are so critical for the development of talent at a frontline level. The appraisal was seen as key. An effective appraisal is key to talent development, and so often these could be rushed and something that people are not adequately prepared to do. So whilst within my research there was excellent examples of appraisals, what it identified was there was significant areas for improvement, and I think that's also reflected now in the NHS staff survey. The other interesting point is a need for independent careers advice for nurses because of the diversity of careers. Now, the other really important point that was identified, and furthermore we've gone on to do further research within our organisation, was the importance of diversity and BME diversity as a priority within an inclusive approach to talent management. Now here you can see a great photo of Pamela McQuahey, who from our organisation, a staff nurse from cardiac area, who has done a Mary Seacole Development Award, and her focus was on nursing and midwifery and leadership for BME staff. Now her study has now gone on to inform much wider feedback within our organisation, and we have a BME leadership group for nursing midwifery which are taking forward ideas from her findings, and these include the need for mentorship and also reverse mentoring for BME staff and senior managers. We need to have better quality appraisals, and that's something certainly our wider talent management strategy in our organisation is focusing on. And access to opportunities, support and mentoring for our BME colleagues, it's certainly in nursing and midwifery and wider. There needs to be clarity around recruitment and career progression and improved transparency, and that's a key focus of our organisational talent management strategy within our nursing, which this nursing midwifery approach is feeding into. And our trust is formalising talent management process far more through developments such as people forums over the next 6 months. So the interesting thing about leadership and culture is talent can sometimes be seen as a disruption. So the tall poppy syndrome, the fact that talent sometimes gets squashed because it's not seen as normal. So from a nursing point of view, it's so imperative that we can identify talent not as necessarily what we would normally expect, but how do we embrace and welcome diverse skills and innovations that nurses bring. So what would help? Valuing and involving staff nurses, developing our managers as talent developers, looking at the quality of appraisals, clearer career pathways and guidance for staff, more specialty clinical education, and clinical career ladders for our Band 5 staff nurses were key findings from my study. And this has informed our inclusive talent management approach within the organisation, which is illustrated here, which we have fed into from 2014 to 2016-17. So that's the key findings of my study and the work that has informed future planning and practice here within the case study. So I'm interested to see if there are any particular thoughts from others before we move on to look at these 3 examples from practice that I wanted to use to illustrate some of the work that we've been doing over the past 4 years on the results of these study findings. Over to you, Janet. Is there any?
Hi. I wondered whether or not, in terms of I think the findings have been fantastic. I wondered whether or not you built on any best practice from other sectors around some of these really important things around inclusivity and diversity around talent management. And in particularly, I'm really interested in the sort of skills for managers in terms of picking up on the talents of staff and the issues that you mentioned around career progression in particular.
I think from the BME diversity, the research was done 2012-13. So in a way that has now informed further discussion. When I was originally looking at the literature, there was not much evidence within other sectors that I could find. And actually, the work that Pamela has now been doing and feeding into our organisation has been absolutely invaluable. From a point of view of the career development, there are other researchers which I have looked into in terms of inclusivity. So Professor Swales at Huddersfield, I think, is writing much more about inclusive management and talent management. And obviously, the NHS Leadership Academy is producing far more. And I've gained loads through going to the CNO BME advisory group and listening to the conferences and what the staff are saying about what needs to happen. So this is a really key area of priority in terms of talent management for nursing, and we want to learn from others certainly through our organisation. Our starting point has been the work of Pamela and her very interesting survey of our nursing staff on their feelings about career progression and leadership opportunities for our BME nurses and midwives, and that's forming the basis at the moment of our work to take forward. In terms of the career development, sorry, can you remind me what the second question was, Janet? Oh, I can't hear you, sorry.
So can you hear me now?
Yes, I can.
Yeah, I was thinking more around the career progression. I think one of the key things that you mentioned is not having clear routes in knowing what the career options are. So tell us any new developments that are taking place on that front.
Yeah, so this is really, we fed our findings into the shape of caring review. That was absolutely key from our point of view, that this has to become clearer in nursing. We're developing more career resources for our nurses. But interestingly, connecting with our allied health professional colleagues, what we found was it was equally as challenging for them. So whilst there is a lack of clarity in nursing, there is also obviously challenges within other professional groups in healthcare. So we're doing a careers resource, a microsite, so a careers resource directly for our staff to access. And the strands of work fall around clinical academic careers, so how do you start that? The other thing is education careers, how to get into education, development. We're developing an advanced practice strategy, so how do we make it clearer the routes into advanced practice? And also managerial routes. So for those people who are aspiring to towards sister charge of leadership roles, how do we make sure they're supported and developed effectively? So that's the approach we're taking and feeding into the national agenda as well.
Thank you. I'm going to go over to Dom to find out what's happening on Twitter and the chat rooms. So over to you, Dom. Are you there, Dom?
Sorry, my voice is croaking, sorry. Everybody's at the moment currently just listening to what's being said. There's a lot of resonating that this is a really interesting conversation. And I think people are really loving these slides as well. So
Okay.
visualization.
Thank you, Dom. Over to you, Sue.
Okay. One of the things we wanted to share was the fact that although students weren't included within the research that I undertook, students are very much integral as STEM now as our future work. We have a task group. We very much engage and involve our students because obviously they are the future of our workforce. And it's going to be important to connect and see careers and aspirations the younger nurses and the new nurses coming through nursing are aspiring to, particularly when looking at the generational differences in expectations of careers. So what we'll move on to look at then is what the piece of work we looked at in terms of excellence. So one of the findings was very clear that there was no aspirational standards for excellence in nursing available at the time when we were looking at this during 2012-13. And then we'll go on to talk about shared governance and a career option that we've got implemented here. So in terms of aspirational, this is just reiterating about the aims of the webinar. So we're moving on to, we'll now look at the case examples. So for nursing as talent, there's felt to be a lack of aspirational vision or standards of excellence in nursing, particularly over the last 3 years. And the one thing we chose within our organisation was the Magnet Recognition Programme. So when we looked outwards internationally, the only framework we could find at that point was the Magnet International American Centre for Nursing Excellence Programme. Now, what we've done is we have utilised that framework as a map. Whilst not actively pursuing at this stage the credentialing model, we have used the model as a map because the model is based on what is excellence in nursing. And I won't obviously go into the details of Magnet, but it was just to share that we've used it as a mapping for excellence. It's formed the basis of our nursing midwifery strategy and is integral to why we've progressed with shared governance at NUH. So we wanted to set clear, aspirational reward and recognition and empower our nurses to realise the excellence of what they were doing and say we are aspiring to be internationally excellent. And these pictures here just illustrate some of the initiatives working with our communications department very, very formally in a strategic way over the last 3 years, how we have actively sought to promote positive images of nursing, to connect with our community, to develop a professional practice model and implement shared governance across our organisation. Now, this journey to excellence, using a framework to map on, here's just a picture of our Leadership Council, which Kerry Taylor, our facilitator, will go on to talk more about shared governance. But this is showing it is a long journey. It involves learning. It involves taking our nurses out, representatives of our leadership councils, to talk to our chief nurse, to learn at conferences and events, and to understand what does create nursing excellence. And the things we've learned from the Magnet model, the things we've learned around developing talent, they are that the empirical outcomes required to achieve Magnet status and looking are driving improvements in patient care. And one of the things we have liked about it is the international benchmarking. So it's just not enough to say you are good, you are excellent in nursing. You have to prove that through benchmarking against comparable organisations. And the other really important factor which we like, and we're about to progress to implement this within our organisation, is registered nurse satisfaction level. So, and that is down to ward and unit level. So this is another addition on top of staff surveys and the particular results that we utilise. But what are our nurses feeling at ward and unit level? And this is a requirement for Magnet, and the detail is a requirement, so you can show impact and actions that you are taking. The other thing that's key for Magnet is that shared governance is a foundation for Magnet. Now, this is devolved management structure, which Kerry's going to go on to chat about, but it's a clear leadership model. It's inclusive, and it opens up and recognises individuals. And the other thing is clear career ladders. So within the Magnet framework, clear career ladders are really, really important, and education and valuing nurses and midwives. So the components of Magnet, whether you commit to a programme of credentialing or not, the components provide a framework with which to benchmark yourself against in terms of driving towards nursing excellence. So at that point, what I want to do is now hand over to Kerry Taylor, who's our shared governance facilitator here at NUH. And she's also a leadership fellow at Health Education England and has got a wealth of experience in leading and implementing shared governance. So I'm just going to hand over to Kerry, and then she will share with you around how we're looking to influence leadership and culture to develop talent here.
Hello, good afternoon. I hope you found our webinar so far very useful, so thank you very much, Sue. What a hard act to follow. So I'd like to start by kind of talking a little bit about what shared governance is and then how we go on to utilise that to form a culture of inclusive talent management. And I think one of the first things to say is that although our story is about nurses and midwives, the principles can be applied across all disciplines. And by all disciplines, I mean any member of staff who works here at NUH or informs our culture. So that includes our students, that includes our patients, and that's about saying everybody is important. And again, just to reiterate what Sue said, it's about inclusive talent management and how can we make sure that everybody feels involved in the patient journey and in change, essentially. So we really strongly believe Tim Porter O'Grader's philosophy that 90% of decisions about patient care should be made by those who deliver that care at the point of care, or that those who deliver that care should inform that change moving forward. So what we kind of think about here at NUH to do that essentially is shared governance. Now, the term shared governance can be used in different ways, so it's also known as shared decision-making or shared leadership. In business, participatory management or devolved leadership. So there's lots of different phrases that are used, but here at NUH we do call it shared governance. So we, back in 2012, we kind of brought together some staff members on one of our medical admissions units and asked them to look at what changes they felt needed to be made in their area. And one of the first things that they did, amongst a lot of other staff from around the organisation, was to come up with a definition for what they felt shared governance really meant to them. And this is it, as you can see on the screen. And it was about saying, you know, actually our patients at the centre of our journey, and so the people, again, who deliver the care should be informing how that journey is formulated, the policies and procedures that kind of come along with that patient as well. And it's about bringing decision-making closer to the front line and connecting the wider organisation with the frontline staff. So as I've said before, shared governance can be known as other things, but it actually encompasses all four things that are on the slide in front of you. So that's shared leadership, that's shared decision-making, that's shared innovation, and a really important component, and in fact, you can't do shared governance without it, is shared research. So it's making sure that our evidence-based practice is the heart of everything we do, and that's knowing why we do what we do on a daily basis, and stamping out terms such as, oh, we do it that way because we've always done it that way. And in actual fact, that's not necessarily a good culture to be in. Yes, it's great, you know, to be doing things that are kind of always done, and if it's done in the right way, but are we up to date with the research that we're using? I mean, let's face it, otherwise we'd still be putting oxygen and egg white on pressure ulcers. So it's about saying, actually, what is the most up to date? How can that inform our practice moving forward? But getting the staff themselves who look after those patients to recognise that and to make that change. So this is essentially our model here at NUH. We employ voluntary participation methods. So again, going back to that inclusive strategy of talent management. So what we're saying is, actually, anybody can be involved in these councils. We call them unit practice councils or ward-based councils at the front line. Each area is entitled to, is more than welcome to, have a council within their ward. And we also have a community council, so because we do have a community midwifery team, but for the purposes, I'll just talk about wards for now. So again, all about voluntary participation. So what we do is we put posters up on the wall in the area when they've made contact with our team, with a couple of people, maybe one, come and say, we really want shared governance in our area. It's something we really feel that will enhance our patient journey, will enhance staff satisfaction. And we ask them, are you passionate about patient care? Do you want to have a voice? Do you want to further develop your leadership skills, your professional development? And I leave the posters up for a couple of weeks, and I go into handovers in the morning to catch the day and the night staff, and I explain what's on offer, what we can give to staff members through doing this, and then we wait for them to come to us, essentially. So it's saying, you know, is this something you want? This isn't a promotion, this is about linear career development. So actually, I feel at this moment in time in my career, I want something extra, but I don't want to go up that managerial pathway. That's not for me. I just feel I would rather develop further skills around leadership, around understanding the wider organisation. So the largest number of names, for example, that we've had for a 7-person council was 47 names. So as you can imagine, really, really kind of key and exciting opportunities for people to have protected time. And that's the crux of this. So we're giving our staff 6.5 hours a month protected time to come together in a room and to say, what are our issues? What are our problems and our concerns in our ward area that affect patient journey, patient safety, patient satisfaction, but that also affect staff satisfaction. So it's not just about saying you have to discuss everything to do with patient safety. It's saying what affects the whole journey, whether you're a staff member or a patient member, and how can we inform that in the wider organisation. So each one of these councils elects their own chairperson. What we do have on a couple of our areas now is the councils, a couple of the people who would like to be chairs of these councils do anonymous manifestos, and they've been putting them up on the wall in their area and having all the staff in that data recovery, actually, in that kind of team nominating who they wanted to represent them in the wider organisation. And it was actually a non-registered member of staff that was elected as the chairperson for that council. And really, really key opportunity for her to develop skills, because we know that she would like to go on to her access to nursing and then to go on to complete her degree. And that's a really great opportunity for a career pathway and for her to network throughout the wider organisation. So to do that and to operationalise that, all the chairpersons of the councils on the wards attend our monthly leadership council. So that is with our chief nurse, it's chaired by our chief nurse. It has other organisational key stakeholders around the table as well. So people from procurement, from finance, Dr. Joanne Cooper, our head of nurse and midwifery research, learning and organisational development colleagues, lots of different people who are there to help make change for the staff members. So it's not a meeting where people come and they expect to be told what to do. So the format of the meeting is very much, we have a 20-minute key speaker at the beginning, which is chosen by the chairpersons of the council. So we've had our chairman of our board, we've had our chief execs come and talk to them about leadership, about complex change. We've had, when we had our CQC visit, we had somebody come and talk to them about the kind of bust the myths, so to speak, around what our CQC visit was going to look like. And so that's the first 20 minutes, and then the rest of the meeting is about them. So it's about them saying, this is what we're working on at the moment directly in our area, this is what's going well, and this is what we need help with. And that's the job of the people, other people around the table to help them make the change. So rather than, again, that top-down approach of this blanket initiative, we're going to do this for absolutely everybody, we're saying, what's key in your area, and how can we help you make that change? And throughout that whole process, we're continuously developing these staff members, we're continuously giving them the tools to understand how to write a business case or to be a more assertive leader. The continuum is absolutely huge. And so what was really key through that was, with now us having 34 councils, the one leadership council, and we're in the process where we set up now our evidence-based practice council, which is to inform our evidence-based practice agenda throughout the organisation. It was really important that we understood what the feedback from staff was. So back in 2014, we surveyed, get the figure right, 3,732 of our 4,500 nurses, midwives and ODPs. And this is what they said. So they said that nurses on my ward take an active role in contributing to decision making. That was the question. Only 12.5% of those 3,732 32 staff agreed with that. And actually, that's really worrying. So that's saying, is it because they don't feel they can? Is it because they don't have the confidence? Or is it because there's no mechanism to allow them to do so? They don't have the time. Moving on to 2015, we did an interim survey of all of the council members that sit on the 32 councils. So in total, we have approximately 200 staff members on those councils, ranging from students to our Band 6 deputy sisters, and then with other MDT colleagues that sit there as well. And we surveyed them. Now, again, important to emphasise, that is a representation of the rest of their ward areas. They've been chosen or elected to be there in the first instance. And this is what they said. 200 staff members said, I feel more able to develop and improve practice. And 81% of those said, I've had the opportunity to develop leadership skills. That's massive. That's absolutely huge. And again, that's completely relying on voluntary participation methods. So that's them putting themselves forward and said, yeah, I'm ready for something else. And the quotes at the top, as you can see, that's only 2 quotes of 200 because we asked for some free text as well. So really, really key agenda moving forward. And I won't go into too much detail, but as you can see on the screen, this is some examples of some of the work that has been achieved by our council members. And again, it's on a really vast continuum. Each council, and we have 34, works on probably up to about 8 projects, as they call them, at a time. So they get support from all their management teams to make these changes and to do these projects, but they're working on some really key organisational strategies, and it's actually how they, again, get that support from around them to develop them and also to make the change. Now, what we've seen really clearly is people who have started to develop these skills who maybe would have at one time thought, I just want to be a staff nurse for the whole of my career, and I'm happy doing that, and that's okay. But once we've put them into, or they've asked to be involved in this, they've started to see that there are actually other opportunities for their careers, and so it's allowing us to say, okay, so what is it you want to do? How can we make that happen for you? How can we signpost you to different places or to different opportunities that will give you further development? In particular, lots of the national scholarships and the opportunities through Health Education England or kind of through the organisation itself, we're able to directly send those to the frontline staff members, so it stops the blockers in the middle as well. So, you know, usually if you send out a secondment potentially to matrons or sisters and they're struggling with their staffing levels, they might not send it out because they'd rather their staff didn't leave. But actually, we should be saying everybody has the opportunity to apply for this secondment, not just because you work on a ward that is well staffed at the time. We should be including absolutely everybody in all of that. So directly sending it to our councils and saying, can you disseminate this through your wider staff group, has really kind of been quite a key element of this. So my input from this was, at 6 months qualified, I chaired the first council in the organisation. I'm now 5 years qualified and have had amazing opportunities by just being involved in this, in shared governance. I've project-led shared governance for the last 2 years of my career, and in the last 6 months have also had the opportunity to work with Health Education England as a leadership fellow. And I know that if without the shared governance opportunity, I wouldn't be in a place that I am now. And we're seeing a lot of other people being able to do that as well, and kind of really coming through the system now. So really key area of work for us around talent management. Thank you very much. Have you got any questions? Sorry, Janet, I can't hear you.
Can you hear me now?
Yes.
Yeah, that was fantastic, and it's so great for you to have shared your personal experience of what's worked for you. I've got a couple of questions, and I'm going to hand over to Dom in the Twitter room, the chat room. I just wanted to find out, in terms of measuring the impact of your work, it feels like there's lots of people involved in lots of different strategies of how they actually get their voices heard around, really bringing their personal interest into their work interest, and using the councils to actually experience work in a different way. I wondered, have you thought about how you're going to measure the impact of that? Because you mentioned something around how it links into the work strategies at one level. I was just really interested to find out if you were to compare yourself with another trust or another acute trust, how would you compare yourself in terms of organisations that don't have the same appetite for this sort of work?
Okay, absolutely. That's a really key area for us. So part of the start of that was to do that engagement survey. So it was to see where we were at the time, and that one question that I showed you was actually part of a much larger range of questions. Part of the Magnet framework that Sue has just talked about is about measuring unit level staff satisfaction data. That was one of the key kind of areas. It's saying, where are we now, and then benchmarking ourselves internationally against other organisations and where they are, because again, as part of Magnet, shared governance is kind of integral. So it's able to say, oh, how's our staff satisfaction doing at a unit level, and not what a lot of the current staff satisfaction surveys that we do. We're able to say, okay, the one ward at the Queen's Medical Centre, they're feeling like X, and another ward without shared governance potentially, because we do have almost 100 wards and only 34 councils currently are feeling like Y. So it's how we utilise that as part of the governance. And then the further piece of research that we'll be doing is how staff feel connected into the organisation and utilising something called the IPNG tool, which has translated into the UCU. So
we're having a little bit of problems hearing you. Yes.
Oh, can you hear me now?
That's okay. Yeah, I can hear you now.
Sorry. Utilising to see how staff feel connected into the wider organisation. So whether they feel in control of their practice, whether they feel that they can contribute to change, how autonomous they are, or what authority have they got within that. So we're in the process of doing that, of measuring councils who are in just at the new stages of setting up their council. So
that's fantastic. That's fantastic work. Can I just hand over to Dom to find out what's happening in the chat room and on Twitter?
Yeah, there's been a lot of agreement that there's absolute love for the shared governance, and one of the things that really stood out is the idea of protected time for staff to be involved in this type of work, and that really resonated with a lot of people online.
Yeah,
thanks, Phil.
I think that's just to interject, that's the difference between a lot of these, of kind of how we operationalise that on board are really key in making sure that happens, and by having our board kind of run this with us, it's not they're telling us to do this, they're right by our side, is integral and key to making that work.
And how did you get your senior management on board with this? How did they feel about this? Because it's almost like a cultural shift as well within an organisation. So in order for it to be sustainable, you've also got to have that sort of top-down to bottom-up support, but you also have to have a cultural shift. How did that happen?
It's a long process. It's still ongoing.
Okay.
We needed our director of nursing at the time was really key in making that happen. You're right. You need that top-down to encourage that bottom-up. Now that we have, like I say, we've always had board engagement, really. They were really keen to get this going, and our kind of divisional nurse and assistant director of nursing management. Once we piloted that first council, Joanne Cooper, who we're going to hear from shortly, led the work around the first pilot council. And so a lot of the outcomes that come from that, particularly a huge reduction in complaints from 28 to 18 in a year on noise at night alone in one area. That real change, that tangible example, got a lot of people on board. So thinking about that change curve, those people that are still those laggards that are still moving up and along, but in actual fact, that culture, and this is about a culture of inclusive talent management. It's not a plaster that you can stick over something and think you're going to get staff engaged. We're still on that journey, although it's been very exciting.
Thank you so much. We're having a little bit of problems with the sound quality, but I think we've got the message from you there. Thank you.
Thank you very much. I'm going to hand over now to Dr. Joanne Cooper, who's going to talk to you a little bit more.
Thank you.
Hi, good morning, everybody.
Hi.
Right, so just to introduce myself, I'm Joanne Cooper. I'm Head of Nursing and Research at the Trust, and it's my pleasure this morning to share with you another initiative that we've started to develop, and it's in its early stages, but we're working on it going forward. And it really links to the work that's been showcased nationally, but particularly in relation to Sue's research around some of the challenges that people have in terms of perception of leadership careers and clinical academic careers. And as head of nursing and midwifery research, clearly it was a concern that people thought that research careers were boring office jobs and not something that you really wanted to do. So I certainly had vested interest in moving this forward. And then the best bit's going to come when you're going to hear from someone who's actually undertaking one of these roles. Ted will be coming up shortly to share with you his experience today. So just returning then to some of the key things that Sue's research identified. And it's really about diversity, and these are the words that stuck out again to me this morning, the inclusiveness of it, the visibility of careers, the opportunity to try something, to learn right from the front line, from being a Band 5 staff nurse, a Band 6 midwife early on in your career, or an allied health profession. If you don't know what you don't know, how can we create opportunities for people to get that insight right at the early stage? So at the bottom of the slide here, it talks about a clinical career ladder, or as Sue referred to, some sort of a framework, a climbing frame. How can we strategically make that happen? And that's what these Chief Nurse Fellow roles are about, really, in a nutshell. But just before we go on to look at the role in more depth, I thought it would be useful to put this into context, because we've also heard a lot about culture this morning, and how whatever we do has to fit within a culture. So a bit of an insight into the culture at NUH that's helped facilitate this. Clearly we have a research active culture, dominantly within medicine, but more and more so within nursing, midwifery and allied health professionals, and a very supportive multidisciplinary team in taking that forward. We've had opportunities to support research and innovation scholars, those undertaking new careers such as the Mary Seacole Awards, Florence Nightingale, also HEAN, and Health Education England Fellows. So that's something that we've been able to support going forward. We've been very grateful to get that opportunity. We have now 3-4 years in process of an evidence in practice course, which is multi-professional. It gets staff nurses to appraise a literature for the first time, perhaps in many years, or to understand and take a small project forward. So they're keeping those skills right from qualification, and it's proving really valuable for those that have been qualified a short time to those that have been qualified, like many of us, a little bit longer. We have, and you're all very welcome to have a look, we have an NUH publication group which is facilitated by Liz Shabbat, who's a PhD student with us, which is great for connecting people. Our Evidence-Based Practice Council, which Kerry's referred to, is about how we learn, not just do policies and guidelines and audits, but how do we share and showcase knowledge from dissertations and so on. We provide regular clinical academic career mentorship. We engage staff in annual point prevalence studies where they can see research in action. But a new initiative that we're going to talk about now are the Chief Nurse Excellence in Care Junior Fellows. And so if you remember Junior Fellows, because we put that in intentionally because this is the beginning of a journey and we'd like to develop Excellence in Care Senior Fellows and so on as we develop what these might look like. Here's a picture of some of our fellows. There's a couple that are missing, one that's going to be newly starting, she's moving to Scotland, and another that's undertaking her Master's in Research at the moment. But you'll see here, from the left, we've got Frankie, who's within children, she's looking at transitioning care. Sharon Layton, who's looking at nurse at discharge within CAS. There's Ted, you'll be seeing him shortly, who's looking around shared governance, particularly patient-focused issues. Andy Sunderland is our Chief Nurse in the middle. We have Kimberly, who's she's an ODP within theatres, so it's not just nurses, it's ODPs and allied health professionals can take this model. She's looking at infection prevention and control and how we can educate staff in relation to that. And then there's Rose Exley, who's going to be looking at stoma care, colorectal care, these are the areas in which they work, and that's really important. There's Helena there, who's looking at dementia care in recovery. And then on the right is Dr. Joseph Manning, who's acting as one of the mentors as part of the structure that we have. So you'll see that there's a diverse group here, but also very diverse topics. and things that are relevant to the clinical area. That was absolutely vital in ensuring that we would get the engagement to make these roles work on the water system to assist, and it's been absolutely extremely supportive. So what are the roles about? This is a list of some of the key things here. So Band 5 generally, or Band 6 in midwifery, because midwives go on to Band 6 a lot earlier, and I think about that in the first instance. That's really important. Essentially, they have 0.2 full-time equivalent to work on the project and their development. So this is as much about developing the fellows' leadership insight and their own confidence as it is about the project itself, but the two are mutual and they are hand in hand. We establish formal mentorship and networking. So if perhaps some of us think back to our career or lack of insight into opportunities, how do you understand what decisions and how decisions are made in the NHS as a junior member of staff? Often by the time we get to more senior positions, we've not had those opportunities. So it's about visiting other areas, speaking to key experts and learning from them right at the outset. They'll have some leadership development, and then we work with them to look at both the clinical and the academic CV aspects that they have and to see where they would like to develop. They might want to be clinical academics, they might want to be ward sisters. This is about unchargedness. This is about looking at what their opportunities might be, or maybe very happy to be those key evidence-based translational leaders at the front line. So they are all assigned a Chief Nurse Fellow Mentor. That would be a clinical and an academic mentor. We use the VITE framework and to help map against their strengths and their development needs in our project plan. The photo that you saw was from a quarterly leadership meeting that they have. Mandy Sunders is our Chief Nurse. And already I've been given tips and some requests for next quarterly meeting as to who else they would also like to hear from in terms of leadership going forward. Just that opportunity to hear Mandy's story. They gave some insights and to share their projects and ask questions. We have great support from our divisions, and it's about how they also engage with the division-related activities to understand how the challenges come to the division and how they're managed and resolved. And each of the fellows' project will be a key element of our evidence for magnet journey and the excellence journey that we're proposing. And the time of the 0.2 full-time equivalent ranges from 12 to 24 months. And if I can address the issue of funding here, the majority of funding is taken from vacancy. So this is a vacancy-funded initiative in a sense that we have roles we can't fill. Why wouldn't we use some of that funding to both recruit new staff, but also to retain those that we wish to keep within our organisation who are excellent? I've just provided a diagram here just to show an illustration of how that mentorship support might work. So we have an element of clinical support, both from an academic side and from that side, but then also really showing the important role of the lead nurse within the division, and also whoever is the named mentor, whether it's a ward sister or someone as a practice development role, for example, within the division. But corporate support from both myself and from Mandy going forward. So each of the fellows will have one of these populated themselves. It's important to show where everybody's role is. And then, as my final slide, it's really about how we're going to see what difference they make, and that impact is very important to show. So we've got some thoughts we're going to develop this as we're going on. But really, so my questions are, did we recruit and select the right people? Were the criteria that we used relevant and suitable? What about the support and development mechanisms that we've proposed? And already we're getting feedback in terms of different things that might be needed. What about the division-related opportunities? How useful are they? What did fellows learn from them, and how could we build the next ones coming around? Then in terms of the support, the project, the quarterly leadership meetings and the mentorship. And then how we can capture going forward the project-related outcomes, but then also the outcomes and the achievements for the individuals themselves and how that impacted on them as an aspiring leader of the future. And we're looking to get some independent analysis, both using qualitative and quantitative outcomes in relation to these reports. And here's Ted, so we're also using his picture in recruitment and retention strategies. Sure, he'll be all over Nottingham at some point. And each of the fellows are blogging. This is a copy of Ted's blog here for the nursing time, so please keep your eyes peeled for that. So I'm going to stop now and hand over to you, Tev, as you can share your experience. Thank you.
Right, good morning everyone. I hope you can all hear me loud and clear. So yeah, my name's Ted. I'm a staff nurse that works on the cancer admissions board, but obviously for the North Point to work with my president, I do the chief nurse fellow position. I've been in the role now since about April time of this year, so I've kind of been one of the longest standing chief nurse fellows. It's kind of been a mixture of a personal development role for myself, allowing me to sort of develop as part of my sort of continuing professional development and some lifelong learning that nurses go through at the very start of my career, because I'm only 3 years down the line for becoming qualified. Having been part of the journey through the student task force group, which obviously we've mentioned earlier on in engaging students from the beginning, it's something that I think I've kind of been brought in order to maintain the retention here that NUH is trying to engage from the very beginning, which is obviously something that this role is inevitable to try and create. It's quite a new role that obviously the Trust is developing, and for our aides that are currently in post, it's something that ourselves we are still finding our feet for. We haven't really got any set criteria, which I guess is both a help for us to develop our role and to improve it forward, but it's a hindrance in the fact that we don't really know what we're doing and we don't really know what we're going to be finding out. Therefore, we're literally seeing what doors open and we're just going head first and jumping on through, which I guess is a benefit that I've quite enjoyed from my role. I've been looking at a safety element as part of the board that I work on, and just by emailing people within the Trust, it's been quite eye-opening to see how engaged that everyone seems to be in order to help improve the whole NUH for the better, which is really, really great to see. And it's something that's quite surprising actually, that they're willing to listen to someone sort of from the bottom, effectively, from the front line, that wouldn't necessarily be thinking and liaising with these type of people. Something that has really made me think about is the way that Nan Sunderland has got massively on board with it, and obviously her allowance to go ahead with this kind of programme from the top down and allows the bottom up to flourish, which is obviously something that we've been mentioning quite a lot from this morning. Within the role, we obviously have open opportunities to develop for further clinical academic careers, developing into PhDs, and any other sort of futuristic project work that these obviously opportunities will allow us to gain skills, knowledge and leadership that we can use for the rest of our nursing careers. It's something that is sort of something that at the very beginning of our careers, something that is great to build the foundations of what will then be hopefully our amazing future nursing careers, and obviously we'll see what opportunities open up from the future really. It kind of allows us to work within our own ward areas or our own department areas to improve the day-to-day activities that we do within these wards, and it allows us to be fully informed of the political standings of the NHS and kind of where we kind of see ourselves in the future, and allow this culture change that I think is something that's happening here at NUH to engage and empower these frontline members of staff to keep on with this good frontline work. And obviously engaging through shared governance as well is something that we, as part of my project at the moment, is allowing us on the front line to empower on forward. The position has also allowed us to network with different people, as I've mentioned earlier, allowing us to network with a chief nurse. And I think that's about from my perspective the role for the time being. I don't know if there are any questions from anyone that wants to sort of nab me while I'm sat here.
Hi, thanks very much for that. That was really, really helpful. That's given us a real insight into your work. I think people are talking about how experiential and developmental your work is, and that's quite new. A lot of jobs are very defined, very specific. I'm really enjoying hearing a little bit about how you can explore and use your own imagination to develop your role. I think that's the way of the future, is using imagination, using all the range of skills that you have to develop your role. How are you feeling about that? Is it quite scary, or is it something that you're welcoming?
Like I was saying, it's been sort of one of the hindrances as well as the helps for the role. It's been quite difficult to try and, when I first started out, and it's something that I think all of these chief nurse players have commented on at the beginning, is kind of the lack of where you start. What do I need to do now in order to try and work out a plan for my project or my intervention that I want to try and introduce? And I mean, linking in with the coaching that we are having through the educational leadership that I'm having, as well as obviously Dr. Joe Cooper liaising within my divisional leadership structure, has allowed me to network with these people who have opened these doors for me and allowed me to try and engage with people that I would never really speak to within my Band 5 role normally. But I mean, obviously, as there is no sort of tight strings attached to this role, it allows me, as you say, to use my imagination, to use my skills, thinking outside of the box, effectively sort of broadening my horizons and sort of engaging in areas that obviously linking with people I've not met before, and obviously trying to push forward for this change of culture and this kind of dynamic diversity of improving knowledge and leadership for the future, really.
Thanks, that's really helpful. I'm wondering if Dom's got any comments in the chat room, or...
Nothing additional to that. I think just like Laura Haley says, do the CNFs have coaching? That's probably one of the questions that got missed up there.
Yeah, that's something that I just saw pop up on the feed, that's why I sort of mentioned it. So like we saw from Jo Cooper earlier, that she was saying about the structure that the role has. I can see if I can try and go back to that slide, actually. I don't know if I can or not. I can. It was to do with the structure that myself, my ward manager is really on board with me to allow me to effectively fly my wings and meet with the people that I need to. The protected time element is something that allows you to be flexible, and although some of the chief nurse fellows have set days on Mondays, because I try and engage with other people around the trust, I try and be flexible with my hours. Although I stick within the hours that I've given, I can try and move them around to meet with people and liaise with people that I need to speak to. And it also allows me to speak to my ward manager for coaching, and then also my divisional nurse for any input. And it's been really helpful that obviously with Joe Cooper's help, we've been liaising with the educational roles through coaching and leadership with that. And furthermore, the divisional nurse that I'm been liaising with has opened opportunities for me to look at presentation skills. So I'm going to go on a course in a few months' time in order to develop myself, to present myself better for these kind of conferences, and trying to develop myself further, like I said earlier, for what would then be my future nursing career and skills that I can use now and build upon for the rest of my career.
I wanted to ask you, did you ever envisage that when you came into nursing that you'd be doing this now at this stage of your career?
No, not at all. Kind of a bit like kind of what James was mentioning earlier about this kind of, you come into nursing and you don't necessarily have tunnel vision for sort of like the nursing pathway and the nursing career pathway. And I don't think certainly when I first started, I didn't see it from the opportunities and the sort of framework and the ladder that nursing opens up to you. And you kind of, I think because if you were ever a patient or a visitor to a hospital, you see the frontline staff of sort of like the Band 5s and the Band 6s that work on the ward and the deputy charge nurses and deputy assistants. You then see the ward manager, and you kind of are focused in that kind of mechanism for that's the only route within nursing. And I think once you come into nursing, you can kind of see that there are other opportunities, other people within the organisation that don't necessarily have a patient or sort of like a visitor sort of visualisation that you can see when you walk into a hospital. It's obviously the key stakeholders that empower the hospital to run as it does, and to allow that people across the organisation to keep it going day after day. people that you don't necessarily see. And obviously, yeah, this role has obviously opened my eyes to many other people within the trust and other key stakeholders that are trying to push forward for allowing the NHS as a whole to have its culture shift, to improve the talent management, and to obviously engage with the future nursing workforce. I can hear you now.
Thank you, that's been really helpful.
If there's no further questions, I'll pass you back to Sue Haynes, who will conclude the session. Thank you very much.
Hi. Thanks ever so much to Ted. I think that was a really fantastic illustration of the experiences in this very, very new role and opportunity, and a great effort to be here with us and supporting this today. So thanks, Ted. So I just wanted to summarise some of the points really, Janet, if that's okay for colleagues. I think what you've heard from both Kerry, Joe and Ted are the absolutely critical nature of us promoting nursing, particularly in these light of these shortages and the need to retain staff as well as attract them. You know, we need to be talking about nursing as talent, as a profession with opportunities. We need to be promoting inclusive strategies for talent management across the NHS because we are really, it's imperative, particularly as well the public understand what nurses do. And it's really key in terms of our professional image and people's understanding of roles and the diversity of careers that are open to nurses when they've qualified, which is so diverse. The slide you see in front of you, this is how we are getting talent management, and I mean inclusive talent management, on the agenda at nursing meetings. It's our developing our strategy. So we want to talk about inclusive talent management at every level of the organisation, so people can start to connect and understand that nursing offers talents, and it's an integral component of the workforce that needs to be valued and recognised. So this is our model that's emerging, and you'll see at the centre, shared governance is the core of that. So that's the inclusive model that's embracing diversity and culture change. But it's a cyclical process, so it has to be talked about and managed, and we need to consider this because of staff retention. It's so critical moving forward. So implications for practice. We've just got some couple of points, and it would be great for people, you know, feeding back after this event. We'd love to hear from other people about what they're doing too. So we're saying implications for practice, both from the research findings and the work we've done over the last sort of 3 to 4 years. It's about inclusivity and diversity in talent management. So it's about particularly increasing BME staff development opportunities and representation in key roles within nursing and wider. That leaders, certainly in nursing and wider healthcare, need to consider talent management wider than the boundaries of their own specialist areas or organisations. Because what we so often find, I think, and anecdotally and through the research I've done, is people may consider their own ward, their own department, their own organisation. But certainly in light of 5-year forward view, how we are developing nurses with talents to work across healthcare boundaries and shifting contexts of health and social care. That requires chief nurses and other leaders to be coming together to talk about these shared opportunities. And it's certainly one thing we're looking at here, with more rotational posts across our healthcare community, with chief nurse colleagues in primary and care sectors. We need to be looking at how we evidence nursing excellence. So it's all right to say we are excellent, but how do we actually prove that? What are the patients expecting? What is staff satisfaction and recruitment and retention of our staff? And there's opportunity for learning across our professional groups, allied health professionals and other colleagues, because it's about recognising and valuing diversity, and that's one of the ethoses that I think we really want to fully embrace for nursing and midwifery here. So just moving on, then clear career pathways are essential for nursing, particularly in nursing, where we are recognising nationally as well as within our own organisation the need for this. The other point is the recognition and value of the staff nurse role as a career choice in its own right. People who do not wish to progress to other roles, who do not wish to progress into managerial roles, need to be valued and recognised for the staff nurse role in their own right. And what we're learning from, for example, within the States and some of the magnet hospitals, they have things like clinical career ladders for staff nurses, where nurses can get some level of progression, pay progression, for doing exceptional pieces of work or contribution, but they stay as staff nurses. So there's opportunities to explore that, we think, within the UK and in NHS. So mentorship, appraisal, and recognising and rewarding those who develop others. So people who develop talented individuals. So the people who may have somebody leaving their department, but actually they're doing that because they're allowing them to progress. We need to ensure that these people are recognised and not just scrutinised for the fact that a staff member's leaving. And we need to work hard on developing a positive image of nursing and the diversity of roles. And that's both within the region and our local area, and also wider within nursing. And then for research, because obviously my original starting point that we started at the beginning was a research study. And one thing that is really clear is talent management with frontline healthcare staff is a really under-researched area and does require further study. There is research, it's emerging, and there's also research for senior manager roles, leadership roles, and executive roles. But how we retain and develop frontline healthcare staff, who are the sort of the foundation of our NHS, is really key for further research. And that will include longitudinal studies into the impact of the strategies we're doing and what retains staff. We're here specifically, as you heard from Joe Cooper, wanting to look at research into the contribution of shared governance and what Kerry was talking about in terms of how that is developing talent inclusively. And also more of an evidence-based approach to careers guidance for nursing, because there's very limited information available about how best to provide careers advice within nursing and what makes a really good appraisal. So is it about how you are coaching and enabling somebody to look to develop their full strengths and potentials? And further study to identify and evaluate what is excellence in nursing in the UK. So we focused our initial exploration and our mapping on the magnet model, as you saw earlier, from the United States. That's one model, and I know now following Shape of Caring, there's work further underway to look at what does that mean in the UK. What does excellence mean? Because we need to have aspirational standards to attract and retain our nursing colleagues. So I think really that's the summary. That's some of the pictures of our staff taken from work we've done to promote positive images across our community. And down on the left, you'll see there April, who was the winner of our Nurse of the Year award this year, who was voted for by the Nottinghamshire public in our award ceremony this May. So that was a fantastic opportunity to connect with our local public and our local community, and for them to say what they value in nursing. And I think, yeah, so there's our Twitter handles. That's all I have to say, and our colleagues here today. So we would welcome connection and communication. We'd love to hear from people. It's something that we feel really passionate about here.
So thanks for that. That was incredibly informative, challenging. It's really challenged me in terms of my own practice around this area, around thought diversity, inclusion, really looking at how we define our role. And also the power dynamics in terms of that whole process. And you've covered such a broad remit around cultural change, values, thinking about our own learning model in an organisation, and that's something that we're thinking about within Horizon. And there's some key messages in terms of really evidencing what we're doing. So yes, we're living in a context of being fluid and dynamic, but we have to show that this approach works and that it's actually making a difference if it's going to be sustainable.
Yeah, evidence-based, absolutely key.
Thanks for that. And I'm going to just hand over to, I've just got a couple more minutes. I'm going to hand over to John to see if there's anything coming up in the chat room.
I think once again, everybody's really grateful for you guys taking the time out and explaining through a number of those ideas and concepts and the way that you guys work. It's very clear the energy and camaraderie you have amongst yourselves, so thank you for that, and I'm sure that many people that will be watching this afterwards on YouTube, we'll be getting in touch and having more conversations with you as and when they do so. So thank you very much for today.
Thank you, Don.
I wonder, Paul, if you could just introduce the next edition of Edge Talk for us before we close out. Are you there, Paul?
I'm here, Janet. I believe that next Edge Talk is actually going to be run by yourself, talking about the School for Health and Care Radicals evaluation survey that's been released recently.
Okay, that's fantastic. Thank you for reminding me, Paul. thanks for that.
And that will be on the first Friday in September at the same time.
Lovely. Thank you, Paul. I just wanted to say again to Sue and her team, thank you so much. We really appreciate the time that you've taken, your patience in talking us through a very detailed presentation today. It's been fantastic. I've learned a lot, and I'm sure everybody has as well. So a big thank you, big round of applause to you and your team. Have a great weekend. It's going to look like it's going to be really sunny and hot here in London. We hope to stay in touch with you and really have you involved in other areas of our work. I think there's a lot of connectivity between what you do and what we do in Horizons. So thank you to the team supporting this presentation, to Dom, who is looking after the Twitter chat, to Paul, who helped with all the background in making all of this happen, and to Kate for arranging for Sue and her team to talk to us today. So thank you to everybody, and have a wonderful weekend. Thank you and goodbye.
Bye.
Bye-bye.
Bye.